Got it.
Do you all hear that?
Yep.
Yep.
Okay, good. So I'd like to introduce Laura Petrillo, who's a palliative care physician investigator in the Division of Palliative Care and Geriatrics at Massachusetts General Hospital and an assistant professor of medicine at Harvard Medical School. Her research focuses on improving palliative care and supportive care for adults living with advanced cancer in the precision medicine era. Her work is supported by grants from the National Cancer Institute and the American Society of Clinical Oncology.
Say that we're delighted to welcome you, Laura, because the experience you've got as a physician is extremely valuable to our particular group of people. And I think having worked myself as a GP for 30 years in the UK, retiring just recently, and also I work part-time in palliative care in our local hospice, I'm really interested in the overlap between palliative care and the rest of medicine, because I don't think they should be treated separately, really. And certainly as a general physician or a family practitioner, I often felt that my job was to approach a patient's set of problems with a rational state of mind and try and break it down into what the issues were. And for example, if they tell me they have pain, I need to understand, where is the pain coming from? What sort of pain is it? I can't just prescribe a painkiller. I need to prescribe the right sort of painkiller. And the same if someone's feeling sick or some other tricky symptom. And all of that will be really familiar to Laura, who's nodding. I can see you now. That's brilliant. And I think it's something that's easily overlooked by people who specialize in medicine. I think for those of us who work in more generalist roles, we're more aware of it. And what this means is that if you have a patient, whether they're having active treatment for whatever their condition is, be it heart failure or be it cancer or some other nasty condition that is life limiting, actually what we need to be doing at each stage of the game is considering what their symptoms and problems are and how best to tackle them. And I think palliative care comes to that table with a lot of answers and a really intelligent way of approaching it. So I'm hoping that's going to tie in with what Laura's saying to us. And the most important thing, I guess, is for us all to know that palliative care is not the same as end-of-life care or hospice care at all. There is some overlap, but actually people who have years to live may need palliative medicine involved in their care to get the best possible quality of life that they can. So, Laura, may I hand over to you? And
Terrific. Yes, thank you so much, Tess, for that introduction, and Erin. And so sorry for the technical issues. Just suddenly the video decided to start working, so here we are. I'm so glad.
Fantastic. That's good.
Yeah. So thank you so much. I will be speaking about what is palliative care generally. I am so happy to take questions. Along the way is actually fine with me to have discussion, or we could do them at the end, whatever works best for your group. But as Erin mentioned, I'm from Massachusetts General Hospital in Boston, Massachusetts in the US, and I am a palliative care physician and researcher, and I am also an assistant professor of medicine at Harvard Medical School. So palliative care is a young and changing field, and the origin of palliative care is actually, as Tess was mentioning, many people will confuse palliative care with end-of-life care, and I think part where that arises from is that the origin of palliative care was learning to take excellent care of people who are dying of their illness and becoming experts in managing pain and other symptoms. And so hospices were developed. Dame Cicely Saunders in the UK was one of the pioneers of palliative care, and that became recognized as a medical specialty, even though it was something that had been practiced since the beginning of medicine to think about symptom management and end-of-life care, but it became a medical specialty sometime in the last century, and then came to the US with the expansion of palliative care in US hospitals, and then even as recently as the 90s, if you can believe it, in early 2000s. And so that was the kind of initial thought, that palliative care was excellent symptom management for people at the end of life. But then in recent years, there has been a huge movement to move the quality of life focused care that we know as palliative care upstream in the course of dealing with serious illness. So rather than this kind of focusing on quantity of life versus quality of life and having it be an either or, and having a switch from kind of all focusing on extending length of life to all focusing on quality of life, to sort of having a more blended approach to focusing on disease modifying care blended with early palliative care. And then at some point, when for people with life-limiting illness, when quality of life focused care is the exclusive focus of care, that's hospice care. So I've started using the analogy that palliative care and hospice are only as synonymous as the alphabet and the letter Z. The letter Z is part of the alphabet, but we also do A through Y. And so I think that there's been a lot of progress in that A through Y piece of palliative care, and I'm going to share some of that with you today. The big study that put palliative care on the map in 2010 was actually conducted here at Mass General by my research mentors, Dr. Jennifer Kemmel, a thoracic oncologist, and Joe Greer. And it showed that among people, this was among people with advanced lung cancer, people who are randomized to receive palliative care from the time of diagnosis actually had much better quality of life and less depression symptoms and anxiety, and better understanding about the goal of therapy than people who were randomized to receive usual care. And they also looked, because there was that concern that you're either it's either or with length of life or quality of life, they looked at how long people lived. And they were surprised to find that people receiving palliative care actually lived longer. They were only looking to see that they didn't live less long, because that was the fear. If you started to focus on symptoms versus focusing on kind of fighting the cancer as aggressively as possible, those patients in receiving palliative care were still receiving chemotherapy, to be very clear. It's just that they ultimately had better quality of life. And so that was a really huge study that put palliative care on the map and helped launch palliative care programs all over the country and the world. And I was already showing you that it was starting to expand in the 90s and 2010s, but since this study, there has been an even bigger expansion of palliative care. Both palliative care delivered in the hospital, which tends to be focused on patients who have acute sickness or things that are, wrong with them, acute medical conditions that are happening in the short term, or this study, which is the kind of palliative care I do, which is early palliative care. So palliative care provided in the clinic alongside treatment focused care. Usually when people are in the hospital, they're not receiving kind of the chemotherapy or treatments, although that it can be very variable. But relative to lymphoma, the palliative care study that put palliative care for lymphoma on the map and blood cancers was this study in JAMA conducted by another one of my mentors and friends, Arij El-Jawari, who's really the absolute pioneer for early palliative care for hematologic malignancies. And she showed that randomizing patients who are undergoing stem cell transplant to receive early integrated or palliative care early in the course of their hospitalization versus usual care also had improved quality of life, reduced depression, reduced anxiety, better symptoms. And then those patients who had palliative care supporting them through a hospitalization for stem cell transplant also had reduced depression effects 6 months later. So this was a really important study because I think there had been the sense, and there still is, I think, that palliative care is appropriate at the very end of life. It might be appropriate in someone with life-limiting illness where there's no chance of cure, but in stem cell transplant, often these were curative intent therapies, but very grueling. And so the idea that providing symptom-focused and quality of life focused care also helped these patients was huge. And so that brings us to kind of the modern definition of palliative care, which is from the Center to Advance Palliative Care, which is that palliative care is a specialized medical care for people living with serious illness that's appropriate at any age and any stage of illness, and that is focused on providing relief from the symptoms and stress of the illness with the goal of improving quality of life for the patient and family. So these are some of the domains of palliative care: symptom management, psychosocial support, helping people with understanding their illness and what to expect, supporting people in decision-making, supporting people in advanced care planning, which is making your preferences known for future care, and then helping kind of to integrate a focus on spiritual and cultural aspects of care into the medical setting, and then thinking and supporting transitions in care. And I do think that when it's done well, palliative care can address some of the broken aspects of the healthcare system. So we talked about pain and symptom control, which can often be recognized and undertreated symptoms in the course of serious illness. The thing I love about palliative care is that I think we think really holistically about what's going on with someone and their families, and kind of try and integrate that into the medical care that people receive. We focus on things like relationships. We help people achieve a sense of control and regain some autonomy in their decision-making with their medical teams. We think about what's happening with the family and what matters there and how we can find extra supports for people. And then for people who are at the very end of life, we help with making sure that people avoid care that is not helpful or that is not aligned with their goals. So I think that there are some really important and valuable aspects that palliative care can provide, that can be helpful given all the limitations and challenges that people can face in the modern healthcare system. This is just another slide describing some of the benefits. Again, many studies have now demonstrated that there are improvements in quality of life among people receiving palliative care, and decreases in symptom burden. Have shown that palliative care improves depression and anxiety and helps caregivers. And then when palliative care is involved in patients' care, the outcomes that people have at the very end of life are better too. So people end up receiving hospice care more often and have reduced intensive end of life outcomes, like use of the ICU or being in the hospital at the very last moments of life. And as I mentioned, we feel confident that early palliative care, it's not an either or, and it doesn't compromise survival. I really love the Center to Advance Palliative Care. This is one anecdote from a patient who's received palliative care, and she was talking about how it has helped her live well. This was a person who had neuropathy, and she said, neuropathy affected my feet, my hands, and that's how I make money. With me being in pain, I just shut myself out and stayed in my room. But the palliative care team included me in the conference in terms of medication, how I'm sleeping, how's my quality of life. I would not be back sitting in this chair if it wasn't for the palliative care program. I'd be lost. I'm in the driver's seat because they're really concerned about how I feel. So it's kind of identifying and elevating what's important to people. And in this case, this person going through cancer treatment, this woman had symptoms that were affecting her livelihood. And sometimes it can be hard to talk about things like that when you're thinking about, I want to make sure that I don't do anything to compromise the effect on the treatment of on my survival. And it might not feel like those sort of things are worth bringing up, but absolutely talking about symptoms is really important so that they can get addressed, and then getting expert symptom focused care. This is a cartoon that I love, which is about a metaphor of late versus early palliative care. So when people have palliative care late in the course of their illness, meaning that their clinicians refer them to palliative care at the very end of life or in the last moments, as we used to sort of think about it, there's a couple kind of facing serious illness. They think about, we'll think about focusing on quality of life later, but then there's a rainstorm. The clinician runs after with an umbrella. Here, this will help. Oh, I wish I had this earlier, like caught in the rain. And then the early palliative care referral is handing the patient the umbrella and saying, you may not need this yet, but just in case. And a few months later, when they're caught in the rain, they've got the umbrella. I'm so glad we had this when we needed it. So I think this is a nice little analogy about just thinking about handing someone an umbrella. It doesn't make the rain come. I think that that's one of the biggest challenges in appreciating how palliative care, when and why to integrate palliative care. I think a lot of people think, clinicians in particular, think that if they start talking about the umbrella, that means that the rain will come, or that they are asking for the rain, or giving in to the rain. There's all kinds of ways that that can be a taboo topic or feel difficult to approach. But if you think of it in this sort of preventive way, we're trying to think about ways that your quality of life could be impacted by treatment, or by your cancer, or by how things are changing. And we just want to be proactive about making sure that we're doing everything we can to optimize quality of life. So this was a paper that looked at clinician attitudes about palliative care, and specifically among clinicians who treat hematologic malignancies, and comparing to oncologists who treat patients with solid tumors. And because of all the studies that I've showed you, the perception of specialist palliative care has actually come a long way among clinicians treating patients with solid tumors. That's some quotes shown on the bottom. And unfortunately, there's still a lot of stigma among hematologic malignancy oncology clinicians with kind of the ongoing perception that palliative care is end-of-life care, that it means stopping treatments, which absolutely it doesn't, or that it means it's a signal that people are not going to do well, or saying that active treatment isn't indicated anymore because people have failed treatments, which is not language we use anymore, that someone failed a treatment, the treatment fails them. But anyway, these are all kind of perceptions that are out there. And then kind of contrasting that to some clinicians' perceptions who are a little bit more accustomed to integrating palliative care, saying, you know, you're thinking about integrating palliative care, think about symptoms. There's a system, a service of clinicians who specializes in dealing with symptoms, and we could use their help. Like, that's really language that's familiar with palliative care and not threatening. And then this idea of offering it concurrently and kind of co-managing. So I think this study was from a few years ago. Hopefully things have improved since then, but just to say, even though we on this call now have a very evolved and up-to-date concept of palliative care, it isn't true universally. And so you may encounter stigmas like this if you are asking about or thinking about palliative care. So just be prepared that everything I'm telling you is true about what palliative care is and does. It's just that not everyone has kind of come to the same understanding about it. So another big factor, I'll say, in how people perceive palliative care is that we're in a totally new era of cancer treatment in recent years. It's a thrilling time for cancer treatment. In recent years, targeted therapies, immune checkpoint inhibitors, CAR T-cell therapy. I actually added that last one because it wasn't even on this slide, but it's such an exciting way of treating cancer that are just totally new paradigms of cancer treatment. And I think that every time a new therapy is introduced, everything else kind of gets a little bit thrown out. We're in this new world. Everything is so hopeful. All these things that we've learned about, focusing on integrating a supportive care focus, maybe we don't need those anymore. I really feel that whiplash every time. Maybe we don't want to talk about what to expect from cancer. Maybe we don't need to focus on quality of life because we've got this encouraging therapy. Maybe people can handle the side effects of this therapy because it's so promising, or we don't understand what the side effects are yet. So it can be really, it's obviously so hopeful and important. And also there's new things that are introduced with new cancer treatments. So as I was mentioning, things like CAR T therapy and other immunotherapies and targeted therapies can improve survival outcomes and may allow people to get back to their usual activities. And we also just have to acknowledge that effective new treatments on cancer is just one piece of the puzzle. There's the cancer-directed therapy piece and how the cancer responds, but there's all these other pieces: symptoms and side effects, emotions, relationships, how people understand their illness and start preparing for the future, and how things might change. And just to speak for a moment to the novel toxicities, CAR T toxicities are wild. So thinking about the things like neurologic toxicities, cytokine release syndrome, these can be very profound side effect experiences for people to go through that scientists and clinicians are really only starting to understand how to study that, how to identify them, how to treat them properly, how to get people through. And so all of that uncertainty can be a new challenge for people to go through. And then sometimes we'll have new therapies that are kind of thought of as well-tolerated biologics because they're different from chemotherapy, but just because people aren't, vomiting and losing their hair doesn't mean that they might not have side effects that really affect their quality of life. And the other thing that's important to recognize is that treatments can have cumulative toxicities. And so when we, integrate therapies into practice and then people are living longer, it's not always studied what the long-term effects are of staying on these therapies that are helping keep cancer stable. So these are just all elements of uncertainty that affect patients' experiences. This is a study from one of my colleagues, Connor Johnson, also at MGH, about kind of longitudinal patient-reported outcomes. And this is among people receiving CAR T therapy. And you can see that people get to a better, the y-axis is quality of life and the x-axis is just time. And that as people go through CAR T therapy, their quality of life can actually get quite a bit worse before it gets better. I mean, the goal, of course, is for it to get better. And then I think, as I was mentioning too, the other challenge is just not knowing which patients will kind of have a durable response and be in a good place, and which will have challenges or progression of their illness after therapy. But even looking at the patients in the short term, we know that people can go through a really big challenging time with their quality of life when they receive CAR T therapies, in part because of the side effects I was just showing you. This is a friend of mine who's a patient advocate in lung cancer, actually. And she is saying how with novel therapies, she can kind of, she hasn't lost her hair. She doesn't look like she's sick, but she's dealing with advanced cancer, receiving a targeted therapy. And to everyone around her, she looks great. That's how her care team perceives that she feels. That's how her scans look, and others perceive her. You have cancer, I can't believe it. And then how I actually feel. These are all the kind of symptoms and side effects that she's dealing with every day. And they're just part of her daily life, dealing with, rash, diarrhea, fatigue, trouble with word retrieval from cumulative effects of treatment and foggy brain, all of these things that could just kind of be there under the surface. And it's hard to for people to appreciate what's happening, especially when it's not as obvious, when people don't look as sick as somebody with cancer might have in the past. So it's just saying tolerable is relative. When we use those words, these are well-tolerated new drugs. And I'll say too, the other big area that I think new therapies bring is this challenge around communication about what to expect and living with uncertainty, and then how people make lifestyle choices to maximize their health. So this was a study we did in people with lung cancer who are receiving targeted therapies. And again, in this kind of new era, even metastatic lung cancer, oncologists are starting to describe as more of a long-term managed disease as opposed to a death sentence. Not that anybody would describe a cancer diagnosis, that an oncologist would necessarily describe a cancer diagnosis as a death sentence, but in contrast to kind of prior ways that people perceived lung cancer, they're saying this more of a long-term disease, and people might hear people talking about advanced cancer as, like diabetes, something you just have to, that people are living with and will be living with for a long time. And the oncologists in this study, we talked with patients who, described that was how their oncologist talked about their lung cancer with them. And then we talked with oncologists to say, what were you learning? What were you talking about with patients? What were you learning? How were you thinking about how to present information? And the oncologist was saying that the uncertainty that they experience as clinicians really affects how they talk about things, because there's new studies coming out all the time, new treatments being FDA approved. And so even if you have a good conversation and that integrates the information about a therapy that you're offering to a patient, a new therapy could come out in 3 months and things could be totally different. And so that really affects the ability to kind of provide prognostic information. But people are still interested, without a doubt. Patients are absolutely still interested in, how long do I have? How do other people like me do with this treatment or with this cancer? And that's absolutely true among people with aggressive lymphomas, as much as with any other cancer. And this same study, another patient said, my oncologist said there's some people that have been on this therapy for 10 years and are still doing well, and it's not a cure. And at some point it'll stop working, but she didn't say the average. All she talked about was a person that was on it for 10 years. So in the absence of definitive information, sometimes oncologists will focus on this really optimistic scenario, and it can be hard. They're hopeful people and they're doing it for wonderful reasons, but it just can be hard to get that information that people really crave in this situation. Patients in the study that we talked to said, uncertainty kind of has two sides of that coin. It can be hopeful. Where there's uncertainty, there's hope. And because we don't know how long treatments are going to last, but because we don't know how long, there's hope that it's going to last. But then there's also fear that it's not going to last long or work at all. and there's hope. You can hear this person kind of just going back and forth in that uncertainty, and the uncertainty provides space for both of those possibilities. It can also be really challenging. One patient in the study told us, I haven't really found an answer of how not to think about living and dying every day. It's enjoying every moment, but in the back of your head, planning not to be there the next time this moment happens. And then having challenges of knowing what to do. Do I want to work? Do I want to retire? Do I want to keep working until I'm too sick? Do I want to work a little less, figure out how to live on a smaller paycheck? These are the kinds of decisions that people face when they're dealing with an advanced or aggressive cancer, but really have that uncertainty that they're facing about how their cancer is going to respond to treatment. And then it affects caregivers too. This caregiver in our study said, even though she's the one dealing with it, it's part of me that I felt has been lost. And because when you can't see the future as clearly, something really shifts and changes. It can be really hard to make sense of what's ahead. And I found this quote from Merle Mitchell, who's a nursing PhD scholar who really explored uncertainty and illness and made theories about it, and has just described it in a way that I haven't really seen anyone else describe it quite as well. But just to say that as uncertain disease-related or illness-related factors are introduced into a person's life, the uncertainty competes with a person's previous mode of functioning. And abiding uncertainty can dismantle the existing cognitive structures that give meaning to everyday events and reduce the sense of mastery over the events and enhancing the sense of danger. So just to say that uncertainty about cancer and about cancer treatment not only affects what somebody is feeling, kind of that stability in the future that they feel about their health, but it can start to make everything in life feel uncertain. And so just acknowledging that uncertainty is a strong and pervasive feeling that can affect quality of life in important ways. Something that we need to acknowledge. And I'll say this is another important focus of palliative care and something that I think about in my practice all the time, and that we're trying to do in terms of modifying palliative care and supportive care in the face of these novel therapies to sort of address where people are, help people with coping with uncertainty and getting the information that they need in the midst of that uncertainty, but also just being able to learn how to surf. You can't control the waves, but you can learn how to surf in the face of that uncertainty. That's a quote that I love from Jon Kabat-Zinn. And then the other thing that we help people to do is just to focus on the things that are most important to them. So even though we might not know what's going to happen, it's helpful all along the way to make sure that we're talking about what's most important to the person who's going through cancer and cancer treatment, and to their families, so that we can put that front and center in their care. And I always say, if we start to talk and think about these things, early, and then we don't need that information for a long time, great. We know each other better. I know what's important to you. I know what you're worried about and what you're hoping for. And that's just such a huge part of, I think, medical care in general. I mean, the reason that we treat cancers that are life-threatening, the reason we treat them aggressively is to give people more high-quality time to do the things that they want to do. So sometimes we can get really focused on the biologic aspects of what's going on and the physical aspects and the lab values and the scans. And we're really there to treat the person, to maximize the quality of life for the person, and understanding about what's important and then integrating that into the medical care is essential. So that's a way that palliative care can kind of integrate with oncology care, with hematologic malignancy care, to kind of provide that focus. And this is a resource we hope that oncologists, that hematologists and oncologists will kind of introduce these ideas to their patients, but we know that they don't always. And so people can always take the time to go through these sort of things on their own and bring what matters to them to their clinicians. And so this is just one resource of many, but I like it because it's general. It's not sometimes kind of conversations about what's important to people in terms of this specific piece of advanced care planning can be focused on some really narrow things like how people feel about certain, machines or this or that. But I think it's really important just to say, what's most important to you in general? What are your strengths and what are the things that are important to you in your life? What are the things that you're worried about, so we can talk about them? And so that your care team can know about those things. So even if those conversations aren't being initiated, people can initiate them on their own, especially with their families, but then also with their clinical teams. And then the other thing I just wanted to share is a resource, which is this resource, getpalliativecare.org, which is where you can find palliative care clinicians anywhere in the US associated with your medical system. And then the other thing that I wanted to share was that What Matters to Me workbook that I just was talking about. But I think that that's all of what I have prepared, but I am really happy to take questions and would love to hear your thoughts and ideas. When I see that there's some stuff happening in the chat, and I apologize, I haven't been monitoring the chat, so I don't know if we want to start there.
Well, some of what's been happening in the chat is people saying a lot of what you've been saying really resonates with us as long-term survivors, actually dealing with a lot of these issues. As you know, and the you know, she looks fine on the outside. So it's one of those things that I think we all slightly dread, is people saying, "Oh, you look great." I don't feel great, and then you feel like you're being churlish saying it almost. So that really resonates. I mean, lots and lots of nodding heads where I can see people's faces. I think that really resonates with us. So that's all the way through cancer treatments, whether you're having active treatment or not having active treatment. Actually, you may be having symptoms, and it's true for other people too. You might look fine, but you might not be fine on the inside. So this holistic approach that you're talking about, I love. And for me as a clinician, that's what it was all about. It's about the person and what matters to them. So this is all great, and I like the workbook resource you've shared with us. Stan has commented in the chat that about the distance. Stan, thank you for sharing that. Do you want to speak about it, and would you want me to read what you said?
Maybe just briefly, simply. I have just recently started in palliative care with the advice of my advanced heart failure clinic team. At first, that was a pretty scary thought, not understanding fully what it was, because of course, like most people, I associated it with something like hospice care. But my biggest fear, as I told them right up front, was my fear is that your role here is to take over from my doctors, to become a liaison that will no longer allow me to talk directly to my doctors, and that they'll talk to you and that you'll tell me what I need to know to cope with that are going on. And being someone who's kind of in charge of my own healthcare, always very much in charge, that was scary. But I told them up front, and they cleared up the intention of palliative care. I'm early in that process, that relationship with them, but what they helped me to see in a counseling session was that part of the struggles in communication that my wife and I have had lately are that there's a sense of distance growing, and they helped me to see that she's in the process, perhaps, of building the life that she needs to go on and live when you're gone. And she's doing her best to do that, as well as maintain the relationship and communication that you have now, to maintain a normal, intimate communication today, even while you're in the process of your health slowly deteriorating. She has to be also building the life for herself that she's going to have to live without me one day. So that is a challenge that I'm glad they helped me to see it, because I did not perceive that.
Thank you so much for sharing that about your experience. I'm glad to hear that you feel like you're remaining in control in your healthcare, and that you're able to kind of maintain the style of communication that feels important to you. And I can only imagine what this challenge feels like, to be navigating a new dynamic in your relationship. And my hope for you is that you get the support that you need kind of throughout this process as things continue to change. I feel like the only constant is change. It may be that this is where things are now, and with that kind of insight that you have. You remain in the driver's seat in how you're navigating both your healthcare and kind of how the cancer is affecting your relationship, or the heart failure in this case. And I'm hopeful for you that where you land with that insight is a place that is beneficial to both you and your wife. I really appreciate you sharing the story.
Just one more small piece tied into that is one really valuable insight they gave me was to see that I have entered into a stage of grief. I am grieving what I've lost. I'm grieving new losses every week, every month in lessening physical abilities. And I would not have been able to articulate that until they helped me to understand what was happening. Now I can look at it through that lens, and it helps tremendously.
I'm really glad to hear that it's helpful to think about it that way. And I appreciate you naming that anticipatory grief, or that grief for things that are losses that aren't, that are different from the losses that we might initially associate with the word grief. And I think having that insight, again, it just has such an impact on how you approach things. Because I think not knowing kind of where the feelings are coming from, or not knowing what the fears are, can lead to decision making that is sometimes from a place of fear, or not knowing, or anger. And it sounds like you've really found, I don't want to project too much, but there's some element of having, when you have that insight, it can be helpful for getting towards a sense of peace, like having the sense of knowing what's happening, or what you're going through, where your feelings are coming from, that grief and that loss. Thank you. I really appreciate you sharing.
May I respond to that and say several things? Thank you, Laura, because I think your response is also very insightful. And I think, firstly, you just said the constant is change. And I think that's a really important thing for us all to know. Life never stays the same, and changes happen. And being able to accept that and move with them is very important. I think I read a book some time ago when I was really struggling with a lot of late effects, called Living with the Enemy by Ray Owen, which is about dealing with chronic illness of all sorts. And it uses CBT and mindfulness and acceptance therapy thoughts within it. And one of the things that's really stuck with me from that book, amongst many, is that when you're dealing with a chronic illness or a chronic health problem of some sort, and by chronic we mean ongoing, not going away, potentially getting worse, it's like a bomb landing in your life, and it falls on you, but there's fallout in the people close to you and the people a little bit more removed from you. And I think that's quite helpful, because in a way that's what you're saying, Stan, is your illness is affecting you, but it's also big time affecting your wife, because she's right near the middle of that bomb going off. And it does have a big effect. And to each have your own places where you can maybe explore that and understand it is helpful. And the third thing that I think that has really come out of what you've been saying, Laura, is this ability to name, articulate, understand what we're going through. And that's one of the things where I think, palliative care doesn't have the monopoly in that, but I think that that sort of attitude is really highly valued within it. Because when we don't understand what's happening, even in our own hearts and heads, it can be very distressing, overwhelming, awful. We can react in weird ways. Whereas actually, if we can come to a point of like understanding, as you've just articulated, Stan, about actually this ongoing grief of not being able to do this, that, or the other that you could do only recently. But to know that and to understand it and to be able to feel that pain maybe in a way that's appropriate can help you to process it. So all of those things are really important. And they're, in some ways, they're just good, healthy living. They're good, supported, healthy living. And I think that often is what palliative care can bring into people's lives by making it academically acceptable as well. You've done the studies, you've written it up, and I think that helps maybe other clinicians to start to accept it more and include it.
Something that you mentioned, Tess, really made me recall something that I hadn't mentioned and emphasized strongly enough, which is that palliative care, every palliative care team looks different, but it is a multidisciplinary field. And so we have doctors, nurses, social workers, chaplains. And so for some people, doing this element of kind of coping work and meaning making, it can be appropriate with any number of different people in someone's life, both within the medical sphere, like the social worker or the psychologist, or outside, like somebody from somebody's faith community, or a family member or friend. So I'll just say that too, that I completely agree. Palliative care definitely doesn't have the monopoly on these things. And I think of these as kind of palliative care concepts, like the idea of focusing on quality of life and meaning making and what's important, and centering it, but can be something that is addressed in a variety of different settings, both in and outside of the medical sphere.
But I think that palliative medicine legitimizes it amongst the medical community, which has huge value, because doctors, speaking as a doctor myself, doctors can be very tricky, and particularly, I think, often specialist doctors within hospital settings they're so focused, like you say, on trying to do a good job. These oncologists, they want to save their patients' lives. They want to give them hope. They want to encourage them, but actually in treating it from that sort of endlessly positive way, or we're going to, cure you, or if we don't cure, we failed sort of thing, that's not helpful to patients. So to open that debate up is really helpful, and to legitimize it, and to try and get this message across to other clinicians that people can do palliative care and active treatment alongside each other, and it helps.
Yeah.
Very valuable.
And care can get fragmented too, focused on kind of specific systems versus the holistic piece. I want to turn to Rachel. I'd love to hear your question.
Hi, thank you so much for this very informative presentation. I think there's a lot of us who are dealing with the long-term side effects of our early cancer treatments, and it affects multiple things all at once. And I don't know about anybody else here, but does palliative care help with that, like, I'm completely overwhelmed feeling? Because, sometimes it's like all too much. For me personally, I have so many different ologists who are screening and checking in with me. And on top of that, I have to manage those appointments, stay on top of my symptoms. And then, there's the financial piece, which I'm really, really, really struggling with right now, because my doctors are all at Stanford, and suddenly my insurance considers them out of network. So it's just like the overwhelm is huge. And I don't know if, does palliative care step in and help with managing any of that? And
it's such a great question. I think you're naming so many different challenges. The challenges I heard are the kind of physical, but also psychological impacts of just, cumulative treatment over time, and then the financial piece. And then the other thing that you mentioned that I'll give a word name to is kind of care coordination, or like navigating the healthcare system, which is a huge, huge need of just about every patient dealing with kind of any kind of complex illness in the United States. Certainly anywhere in the world, but with our really messed up healthcare system, it's kind of worse in the United States in some ways, because you just have so much care coordination and so much of a burden that's placed on the patient and caregiver to kind of keep track of all the different appointments, to be coordinating across specialists, to be, thinking about drug interactions when they are getting treatment recommendations from different people. I'll say that the way that palliative care tries to help with care coordination is that among physical symptoms or psychological symptoms, we'll sort of help to break it down and focus on the things that are affecting quality of life the most. We address all symptoms. We really think of prioritizing in that way. What is affecting your ability to do the things that you want to do, and how can we address that, whether it's in the office with treatments that we offer, or referring to someone like physical therapy for kind of, exercise or ways to improve strength to decrease fatigue, or to an interventional pain specialist. And so in some ways, the complexity can increase from there when we're focusing on symptoms, but the care coordination piece is another thing that we focus on, just to sort of help people sort through what are the things that are feeling the most challenging, where are the questions and things that feel uncertain. And I would say I leave every single clinic day with like a list of clinicians to email to make sure that I am getting information across or relaying something so that someone's, symptom that might need more workup, gets put back. But I think one big challenge that people have is that when they have cancer, they kind of lose the quarterback, or they need a quarterback in their care. The primary care doctor loses touch because they don't have the specialist expertise. Sometimes the oncology team can be so focused on the cancer that they lose the rest of the health piece, or they become the de facto manager of the blood pressure medication. This is just so much, but ultimately at the end of the day, it's the patient and the caregiver. And so I would say, although I wish I could say that palliative care helps with that navigation or care coordination to the point of view of like relieving the patient and family of that, I would be lying if I said that that was something that we're able to do, but we absolutely can help people with thinking about how to prioritize, how to get the information that they need, how to find support, psychological support for the stress of dealing with it, supporting caregivers. But I was just at a conference this past weekend, the ASCO, American Society of Clinical Oncology Quality Conference, and that issue of kind of navigating the healthcare system came up over and over again as like just a huge thing that people need, and that we're all as a healthcare system trying to figure out how to help manage. Community health workers as navigators is kind of coming forward as one possible solution, just because it's been de facto patients and their family members, but could a kind of lay navigator be sort of trained to be someone who helps, particularly someone who's experienced this type of cancer treatment before, or something that's really promising. But it's something that we're aware of as a huge problem, but I don't know that there are a tremendous amount of great solutions, but I hear you.
Thank you.
Erin.
So first of all, the photo of the woman who had a cancer diagnosis, but had then looked great and then had all these things pop out around her was such a good graphic, and so perfectly explains what I feel like my life is like 50 years later. Because I do look okay, and I don't like saying I've got these gazillion things wrong with me, but I just wanted to share something that happened the other day at Mass General Hospital. I was there for my follow-up in a tricuspid trial that I'm involved with, and when they get done with the echoes and the exams and the testing, and they give you a questionnaire, and I filled this out now maybe 3 or 4 times since I had my procedure, and a lot of the questions were related to quality of life. How much does this issue affect your socialization? You're doing daily house chores, you're going to work, you're having fun, you're whatever. And I've always filled it out pretty honestly. And what's curious to me is that no one has ever gotten back to me and said, geez, I see that you're not able to do these things anymore, or not as much as you'd like to. Let's talk about that. And I've done this several times now for different reasons, but in this particular study came from thinking, what's it's really just for the study, but so they can see, I think, how well people are doing with this new valve, I guess. I don't know. But it made me so sad to think that no one's reading that saying, we'd like to help you. And that's such a good place for palliative care,
Yeah, I'm so sorry to hear that that's been your experience, that those things are things that you've voiced and then not necessarily been able to find the help for. It's such a fascinating thing where there's this increasing recognition that patient-reported outcomes are incredibly valuable. So anytime there's a clinical trial, in addition to collecting the disease-focused outcomes, like the survival outcomes that everyone is highly focused on and that drug approvals are predicated upon, there's always kind of this quality of life focused data that's collected, isn't even always published, to be honest, but then when it's collected in the course of a study, it absolutely isn't, there's no guarantee that it's being intervened upon. But then there've been studies in recent years that if patient-reported outcomes are collected and acted upon, so there was a big study by Ethan Bash that was showing that if people had were reporting these outcomes over, longitudinally, and there was someone reading them in real time and making proactive phone calls and kind of getting people into the clinic earlier for an urgent appointment if they're having symptoms, or being referred for a mental health specialist, or being referred to an occupational therapist to deal with, how their, changes and, what accommodations could be made in their lives to make things easier. Whatever it is that those things triggered, people lived longer. They did better. So those hard outcomes, that the clinical trials focus on, those improved when we focus on quality of life in that way. It's kind of analogous to some of those early palliative care trials. But hospitals are really, and health systems are really only beginning to try and figure out how to operationalize that patient-reported outcome collection and operationalize the response to it. That's the biggest challenge, because you need people who are kind of monitoring it and know what to do. And we absolutely, both in kind of cardiology care and in cancer care and in, all kinds of different, aspects of medicine, we really don't refer patients nearly enough for mental health, screening or evaluation or treatment when people have mental health implications of their condition. And who doesn't? I mean, to be honest, have some implication on their quality of life and on their mental health from their dealing with illness. Is just a huge, huge problem. I appreciate you bringing that up. If you want to message me with the kind of name of this, I'd love to know what they're doing with those data. But it's true on the system, but I was just talking about this with someone, like they sort of dropped patient-reported outcomes into our clinical whole scheme a couple of years ago, and then they quietly stopped doing it. But it was not with a system of like how to deal with it. Like, how as a clinician, you're supposed to, integrate this in your workflow. Here's extra time to be able to address all the symptoms that arise when people are asked to report these things on an iPad when they come into the clinic, or, here's if somebody's dealing with financial toxicity, like dealing with a lot of challenges with paying for their medications or, anything, or having impacts on their life from that. Here's a financial counseling service to refer patients to. I mean, again, I was at this conference and people were presenting all these little homegrown solutions that they've made in their different places, but universally, there isn't some minimum standard of quality care that focus on these aspects of how, health conditions affect people's lives. And so I appreciate you bringing that story to me. And I think we can really clearly see where the growth areas are.
Thank you.
Yeah, thank you.
I think it's almost worse to be asked how you are and then not listened to than never to be asked how you are.
I hear you. There's absolutely
because if someone says, how's it going? And you say, not so great, I can't do this or that anymore, and nothing comes back, then you've opened up and nobody's responded. I mean, I appreciate they're probably gathering the data for their research, but we are human beings, aren't we?
Absolutely.
And, we need to be heard and responded to.
Yeah, absolutely. I mean, I think I don't have, I mean, in the research that I do, we collect all of those outcomes, but it is, and it's funny because we will collect them and then be separately acting on collecting them in the context of clinical care, and the data is there to assess the clinical care that we're providing. So they are related, but I'm not looking at the questionnaires that someone fills out. I'm simultaneously asking the same questions. So I don't have familiarity with the studies where somebody is studying, a procedure or a device or, something else, or, a pill, and collecting those data, but then not using them in real time. It's not a great plan. But the collecting of the outcomes is something that people are actively working on. It's just we're so far off. And I also will say too cynically that it relates to where the money is.
Well, and it's about the personnel, isn't it? And having personnel to do stuff, like people to do things, is your biggest cost usually if you're trying to provide healthcare. Premises is expensive, but people are expensive, and it's a problem worldwide. It's certainly a problem in the UK. We do have we have a nationwide charity called Macmillan Cancer Relief in the UK. Which is there to provide support very much for these sorts of things. So they provide counselling support, financial support, they'll mentor people through things like navigating the system a little bit and so on. And people could just ring them up for free and get help. It is a great charity.
That's
Yeah. And
I do.
they advertise a lot as well, so people know about Macmillan. So hopefully people do contact them if they need them. Yeah.
You know, I'm glad you bring it up because it is true in the US too. I think so many of the supportive care resources that I've seen people availing themselves of are from nonprofit organizations that have kind of filled the space where healthcare hasn't, and kind of peer support, kind of, you know, forums where people can talk to each other or be kind of peer-to-peer mentors with text messaging, and, you know, these kind of walks that people get together to do conferences. And there are a lot in this kind of nonprofit space with a lot less in the kind of official healthcare space. And I do think it relates to sort of how we value healthcare in the healthcare system. And there's been a shift, there's been an effort to shift towards more value-based medical care. And, you know, it's such a long way off from kind of where we are now in this kind of fee-for-service world, but thinking about what do we value? How do we want to kind of pay for that in the healthcare system, so that what matters to people is what we're focusing on. Just because right now, you know, a clinician who spends time talking with someone doesn't get as much money as somebody replacing their knee or whatever. You know, it's just
too right. Yeah. And it does come down to that, doesn't it? You know, someone like me who is passionate about caring for my patients as individuals, you know, you end up burning yourself out really, because you give of your own time, and it's the only way to do it. Because ultimately, it is about each individual person, exactly as you have been describing, and yet that's a luxury in the healthcare system. Even not in a fee per you know, because it's a different system here, but we still have huge financial pressures within our health service. And if they can't count it, they're often not interested in it. And this is something you can't count it very easily, although you have showed us some quite nice demonstrations of pieces of research that people have managed to produce that show, you know, more subjective measures sometimes about proving. For instance, having a named primary healthcare physician who knows you extends your life. You live longer.
Yeah.
But it's not happening.
I hear you. Yeah.
Mm.
So many ways, spaces where we could grow. And I think, you know, I'm hopeful, and I think there's the recognition that things are utterly broken, and that there's ways that we can do better. But until we sort of have that value shift, a lot falls to patients and their families. So much falls to patients and their families.
It does. So we're wondering, is there anybody else in the meeting here today who wants to talk about or is willing to share any palliative care experience that they may have had? Amy.
I recently started palliative care. I've had maybe 3 meetings with them so far. I reached out to them a couple of weeks ago because it felt like I was having a lot of symptoms coming up at the same time, like lack of sleep, anxiety, back pain, things like that. And I got to the point where I was like, well, which specialist do I call? I don't know what to do. So I met with palliative care, and they helped me sort of put in order, okay, we're going to talk to your GP about this. We're going to talk to your cardiologist about this. We'll set up a meeting. My palliative care consists of a nurse practitioner and a social worker. So I'm meeting with my social worker tomorrow to talk about anxiety and sleep. And it's helpful to know that there's another tier of people there to help me just figure it out if I'm confused. But I'm also still a little confused about feeling confident of what's a question for palliative care versus what's a question for somebody else.
It's such a good point that you bring up. Thank you for sharing that, Amy. And I'm glad that you are starting to get some help for some of the things that you're dealing with, and trying, you know, not having to face these things alone anymore. And I'll say to that question of, you know, when do you call palliative care versus calling another specialist? in the ideal world, where I practice, we definitely are a big team. So if a question comes in, it's like, somebody's like, oh, I have chest pain. I don't just say, oh, let's have some pain medicine for that. I might say, we need to find out what's the cause of that chest pain, and vice versa. If somebody calls their oncology team and it's managing a symptom that is an expected symptom that they've been managing with the palliative care team, they might put the question actually over to us. So in an integrated health system, in the ideal setting, your clinicians are kind of working together behind the scenes to sort of be sorting through those questions and making sure they get to the appropriate place. I will usually tell patients, though, that if there's a symptom we've been managing together, like pain, for example, once somebody is starting to see me for pain and I'm prescribing pain medications, it usually comes to me, and my team to just be fielding. But that's another one of those challenges of care coordination. Like, how do I know who to call and when to call, and how to stay in contact? So I think the things that I always recommend upfront and meeting any new clinician is just, what's your role in the team? How do I contact you, and like for what? And then making sure that you get to know each other in that way. That's always a good practice. And it's going to vary place to place about, how to reach them and when to call versus calling another specialist. But you bring up a really good question, and I hope that you gain some clarity about that with your specific team members.
Yeah.
Thank you for sharing that, Amy. It's interesting, particularly at this early stage in your kind of engagement with the palliative care team. So you're feeling your way still a little bit, I think, aren't you? And hopefully these things will become clearer and you'll understand more what goes where. But like Laura says, in an ideal world, your team would work around you and would liaise with each other. Then you may find that the palliative care team are happy to do that. It's something to ask about, isn't it?
Yeah.
Anybody else got any questions? Or Laura, you want to talk?
Well, I just wanted to say I had a similar experience to Amy in that I was really not sleeping more than 3 hours a night. I had so much anxiety. I was just crying all the time. And I've always been really positive and energetic, and even throughout everything. And there's been a lot. But I've always, it's fine. It's one thing and another, and we'll just one thing at a time, take care of it. But I was really struggling, and my primary care physician said, "Oh, here, talk to the social worker." And I said, "What's a social worker?" So I spoke to that person about 6 times, and she helped me to gain a little bit of, I just couldn't focus on anything. And she, through a few sessions, and the last one, we made some progress. The last one, she said, I think you'd really benefit from talking to the people in palliative care about, the issue that you've got this kind of a pain and you've got this kind of a limitation, and she explained all the ways they can help me. Of course, I'd love to, as many people want to come to this party, they are welcome. So, and I too, like Rachel, I'm at Stanford, great doctors. I always feel like I have the A team, whether it's my, vascular person or my pulmonologist or my lung cancer doctor, whoever it is. I always feel like with great doctors, easy to get a hold of them, but also like all of you, you don't know which one to call for what. Okay, I can't breathe. Well, is it my heart? Is it my lung? What's causing it? And I seem to find that speaking to the palliative care nurse has always helped me to prioritize and to redirect. And I always feel so comfortable. We have a call set up once a month, and she said, "I'm always available whenever you need me." And I think, oh, the call's coming up in a couple of days. I don't really have much to talk to her about. Then we get on the call, and I take things really little by little, and she's making notes and this and that, and then she has suggestions about what I should do next and who I should call. And I was complaining about, I didn't know what to do about this, and I've been trying to reach so-and-so to get a blah, blah, blah. And she sort of would let me, and she's messaging, "Okay, you've got it set up. They're going to call you." God bless you, thank you. So I feel like they're a real advocate, really, really active advocate. And so I haven't actually gone in and seen a doctor in palliative care. I may have once spoken to somebody, but I really don't remember it. I remember this wonderful nurse, Eloise, who I speak to once a month. So I don't know, so far it's been a wonderful enhancing experience to have another, as I say, tool in the toolbox, another place to go, another piece. So
Thank you
thanks
so
for
much.
all you're doing.
Yeah, that's a wonderful thing to hear. I think what this is making me think about, so as a GP, most of my working life, I felt very much I should be there to help coordinate things for the patient at a primary care level. And the GP is good for that. But
I used to have one who did that.
did you?
No,
Well, that is great, and
yes,
it's an
she
important
was
role.
wonderful, and then she left.
Yeah, well, there you know.
Like,
But and that is important, and because I think it is useful, and I think also sometimes there's the need for someone more at a secondary care level, and I think palliative care teams, whichever member of the team are most appropriate for somebody, can help to provide that. Because I think while I've been listening to all that's been going on, I'm thinking this is about taking you as a whole person always, and never thinking just about, I got so cross with an endocrinologist who was only interested in my thyroid. And I'm going, there's a whole body around this thyroid, It's not just the thyroid we're talking about. But so we need to be considered as a whole person.
Mhm.
But then within our whole personness being, we need to break it down into what are the areas and problems, and what's our list of issues that we may be having, our difficulties, and understanding those, because it isn't until we understand those that we can then maybe address them and find out who's the appropriate team to deal with them, and get the help we need to kind of put it all back together into the whole of us again. So there's something here about taking the whole of us and breaking it down to, but never forgetting that it's part. Oh, Lynn, thank you for being a whole person, and that's really important. And I do think I'm very encouraged to hear your experience, Laura, that this nurse is helping you with doing that, and I hope, Amy, that you will find the same really with your team. It'll be a little bit different because they're people and you're different, but that sort of ability to take things to someone and work out where do you seek help for each kind of subset of the symptoms and difficulties that you're experiencing.
Yeah, I really appreciate that, Laura. That word advocate is definitely absolutely part of how we see ourselves. And so I'm glad you've had that experience. I apologize. Was there another comment?
Laura, I just wanted to ask, I'm just curious how many long-term survivors like us you see. It never fails to amaze me how many multiple medical issues those of us who are decades out have. So, and I think Rachel alluded to this too. We've got multiple people looking at us, and there just almost isn't any area of our bodies that hasn't been affected by our initial diagnosis of cancer. So I often think of palliative care and I would say hospice as well, being for cancer people. And we're actually not cancer people at this point. We're late effects people with multiple issues that have nothing to do with, they have more to do with the cure than they do with the original cancer. So I think that's where sometimes we get stuck in asking for help at this point in our lives because we're cured of the cancer. So maybe we don't deserve the same kind of treatment that someone who's going through cancer has. So I'm just curious how you would react to that.
Yeah, I absolutely wouldn't ever use the word deserve. I think everyone is deserving of good holistic care in every setting. But I would say there is a function of just how the healthcare system is set up and even how palliative care has grown up as a specialty. And it's something that we're all working to change, which is just to say all kinds of serious illness, people dealing with all kinds of serious illness have needs, have supportive care needs, have physical, psychological, social needs, they have practical needs. And yet palliative care, as it's worked from kind of being involved at very end of life care to being kind of more involved alongside active treatment, I would say that we have the most representation in the kind of active cancer therapy space. And then and kind of that longer term dealing with active cancer therapy and people dealing with, advanced heart disease or lung disease or any number of other chronic issues with high symptom burden or other impacts on quality of life. We absolutely are starting to integrate palliative care in those different settings for neurologic disease or all kinds of things. But that is so much more patchy around the country and around the world of who is starting to think about advanced illness or kind of chronic conditions, palliative care integration. So I would say, and also, you know, it's the active kind of treating oncologists who are doing the referrals to palliative care. So even just the gatekeeping to get over there is usually through the oncology team. So I think it's just a function of how things are set up and where this field grew up as a specialty, and you know how the hospital, like for example, my hospital, we get about half of what we deliver, you know, we get paid for by insurance, but then the other half is kind of subsidized by the rest of the hospital because they think it's something that's valuable, but it's not not profitable. And so I think hospitals, when they're sort of supporting a service in that way, they get to sort of dictate where it goes. And so yeah, it's just, we're not in a state right now where there is kind of this universal standard of care that everyone receives. And so I would say, though, asking for the care that you need is always, always appropriate. And so that was why I shared that getpalliativecare.org website, just to say, you can always find clinicians who are in your area or in your network. You can always ask the person you identify as your main kind of treating kind of quarterback or coordinator, whether that's primary care or whether that's a subspecialist of some kind. Everyone in the healthcare system ought to have familiarity with this. And I would say the other thing that you're naming, Erin, is that survivorship care is a field that's as confusing and not necessarily stigmatized, but like less reproducible place to place. I mean, it's such a variable thing, and really not at all standardized, I would say. Like there's no minimum standard of survivorship care that people receive, and there's no consensus on who delivers it and how often, and you know what sort of elements ought to go into it. There are these survivorship care standards that are really based on the experiences of people who've had early stage breast cancer and then are integrating back into the primary care world. And by no means does that apply to every cancer survivor. And so the things that are relevant for somebody who's had, you know, early stage breast cancer treatment is not necessarily going to be helpful for somebody who had a childhood cancer, or for somebody who has had cancer affecting a different organ system, or, you know, any number of things. So this is an area, survivorship care, just like palliative care. I was showing you all of the kind of ways that our field has needed to become, you know, legitimized in the healthcare system through all these studies and, you know, guidelines being developed and all these different things. The same is true with survivorship care. It's just not a clearly defined medical specialty with a set of standards. So I appreciate you bringing that up, and I hope that it doesn't inhibit from getting the care that you need.
No, thank you. And I just want to, I know we're running up on time, so I just wanted to, first of all, say this has been an unbelievably wonderful presentation. And I think your way of presenting has been so, it's been a gift to us. It's really been lovely. And I just want to ask those who are still here, I'm sorry I've lost a couple of folks already who have had to leave, but this is a moment where we're still recording, obviously, and there's a lot of conversation that's happened post Laura's presentation that I think is really valuable, and maybe valuable, I know would be valuable to others, but I don't want to offer that recording to others unless people here who have spoken are willing to do that. So if you have any major objections, you can message us or whatever, but it would be nice if people are comfortable to be able to share this discussion with others, because I think oftentimes that's when the real meat of the presentations take place, is, you know, that there's a beginning and there's the after, and they're both valuable. So I'll leave it at that.
Well, thank you. I just want to draw your attention, Laura, to a couple of comments in the chat. I don't know if you've been able to see them, but some really positive comments about the helpfulness and the quality of your presentation from people who had to leave already, and how useful it's been. So it's been a wonderful session. I think, you know, I'm not at all surprised that you presented it in such a human and easily comprehensible structure, because you work in palliative care, and that's what you do. You reach out and make things more easy to understand and you know, connect with people. So that's been marvelous. I think we're all better educated for having heard what you say. It's wonderful to hear how the speciality is growing in the United States, as indeed it is in the UK. So we can get in touch with you should we wish to, using your email address. Thank you for that. And I think, you know, just from the bottom of our hearts, we are very, very grateful that you've come and talked with us, listened to us, responded to us so kindly and intelligently. It's been really marvelous.
Thank you so much for having me. I really appreciate you sharing your experiences and your questions. And I hope that you'll join me in sort of spreading the word about palliative care and that we're A through Y, in addition to Z, when you hear people just say, isn't that Z? So yeah, thank you.
Brilliant. Thank you.